Welcome. You're watching a symposium on the coordination of care for the treatment of early-stage lung cancer. The meeting was presented by a panel of multidisciplinary experts from The Ohio State University. Each expert spoke about a different topic on the coordination of care for early-stage lung cancer. In this video, Dr. Jeremy Brownstein, a radiation oncologist, talks about radiation approaches for the treatment of early-stage non-small cell lung cancer. He also briefly touches on stage 3 disease.
The standard of care in many of our patients with early-stage non-small cell lung cancer is going to be operative resection, but that is not always going to be possible, and that's partially because a lot of our patients with non-small cell lung cancer have a fair amount of medical comorbidity. They have, in many cases, been smoking for quite some time and might have poor lung function due to COPD. So many patients are what we would call medically inoperable, meaning that although they do have small tumors, they may not tolerate the surgical procedure because of their medical comorbidity. So patients who are unable to undergo the surgery, we're very fortunate that we can offer them treatment alternative, and that is definitive treatment with something called stereotactic body radiation therapy. So one other small indication for this is every so often, a patient who may be eligible will often not want to pursue a surgery. So it is helpful to have other treatments that we can offer in that circumstance as well. So conventional radiation used to be the standard approach for our medically inoperable early stage non-small cell lung cancer patients. And this would consist of 6 weeks of daily radiation treatments. Unfortunately, that approach does not have a very good, what we would call local control, meaning that in many cases, the tumor would recur right where we treated it. And so it was not really considered an ideal approach. But in the past several decades, through some really remarkable advances in physics and image guidance, new techniques have been made available, such as stereotactic body radiation therapy, which gives a very focused dose of radiation just to the tumor over the course of 1 to 5 treatments. The local control rates for standard SBRT are around 90%, which is very, very good. In my opinion, much better than they used to be for conventional radiation. And the other side of the equation is the toxicity is manageable. In fact, in my experience, many patients, their biggest complaint is they're unconvinced that they underwent treatment because they don't feel any different, which we are okay with. So this is the standard approach for what we would call peripheral lung nodules, ones that are far away from the structures in the center of the chest. Now, there are many times when lung nodules occur closer to airways or closer to structures in the center of the chest. And for those cases, we may use more fractions. So in some cases, we may use 8 or 10 fractions to definitively treat these cases. And that has the advantage, in my experience, of allowing us to be a little bit more gentle in terms of protecting those critical organs while still maintaining that very high efficacy. So here we have a 71-year-old female who presents to her primary care doctor for a routine checkup and has a 30-pack year history and also has a history of COPD. Her PCP fortunately recommended a low-dose screening CAT scan, and that did indeed detect a 15-millimeter nodule that was concerning for malignancy. So her PFTs had demonstrated that she may not be an adequate surgical candidate with some decreased FEV1s noted. So a biopsy was performed and it demonstrated adenocarcinoma. Staging was performed with a PET scan and there was no other evidence of any disease. So this patient was discussed at a multidisciplinary clinic and the surgeons had the opportunity to evaluate the patient as well. And we, as a group, were able to determine that this patient would not be a surgical candidate. So we discussed definitive treatment with stereotactic body radiation therapy. It is worth noting that there are other local treatments besides surgery and radiation for the treatment of early stage lung cancer. And another notable one is patients who undergo a procedure called RFA, radiofrequency ablation, which would be performed by interventional radiologists, whereby they insert a probe much in a similar procedure where they would perform a CT-guided biopsy. They use CT guidance to insert a probe through the chest wall, and they're able to deliver a high amount of thermal energy through either microwave or radiofrequency radiation. They can also deliver a substance that is very cold and perform what's called cryoablation. Now, in general, all things being equal, for non-operative patients, we recommend consideration of something like SBRT before we consider radiofrequency ablation. In my experience, there's also a lot of instances where radiofrequency ablation may not work, like when the tumor is adjacent to a blood vessel. That can act as a heat sink and make it hard to heat up the tumor to the appropriate temperature to achieve ablation. So the radiofrequency ablation has an attractive feature in that the interventional radiologist can perform a biopsy of a suspicious nodule and also ablate the nodule with this technique in a single procedure. And that is obviously attractive for patients who have limited access to a medical center. For our patients who have unresectable stage 3 lung cancer, the standard of care for many, many years, for decades, has been a combination of chemotherapy and radiation. One of the reasons that we were able to offer treatments like SBRT and also better treatments for stage 3 lung cancer is some amazing developments in the world of radiation physics in the past several decades, where we used to previously treat our tumors based upon targeting fields with somewhat rudimentary technology that would be just targeting the periphery of the tumor from a couple of different beam angle perspectives. And we would do this ourselves, and we would be able to treat tumors pretty effectively. But the downside of this is that we'd be exposing nearby tissues to a fair amount of radiation. And this was called 3D conformal radiation therapy. But in recent years, through using advanced computer algorithms, we've been able to develop treatments that in some cases use hundreds of beams from many different angles, where the computer is optimizing to find the perfect combination of radiation beams that allows us to hit what we want to hit and not hit what we don't want to hit. And this has really allowed us to have our radiation carve a very close margin right around our tumor and allow us to spare some of those very important organs in the center of the chest. So this is called intensity modulated radiation therapy, or IMRT. In my experience, it's through advancements like IMRT that we're able to deliver radiation more effectively and safely than we were several decades ago.
Look for more videos on the treatment of early stage lung cancer from the experts at The Ohio State University.